Thanks, Lauren. I'm really excited to introduce our 11th CCC speaker today, Dr. Micaela Martinez. Dr. Martinez is an assistant professor at Columbia University in the Department of Environmental Health Sciences, and she really has just carried out groundbreaking research on the drivers of seasonality in infectious disease systems and the impact of circadian and seasonal rhythms on diseases. Specifically, she's worked on polio, measles, chickenpox, and now SARS-CoV-2. Her work is really about elucidating disease dynamics and understanding how human behavior, human behavior and physiology, combined with disease characteristics to alter the disease dynamics. And so specifically, some of her highlights are looking at polio dynamics, trying to understand how demography of the baby boom versus improvements to public health hygiene have changed polio dynamics, specifically highlighting the fact that silent transmission is readily happening for polio and how it's important when we look towards polio eradication. A very timely thinking about COVID-19 silent transmission as well. She has looked at how the human immune system changes seasonally, and I think she's currently undergoing projects to actually measure human immunity throughout the year, which I think will really show some very interesting results. And you know, one of the coolest graphics I think I've ever seen is from her paper of the calendar of epidemics, where she looked at the seasonality of 68 diseases. And we all know about flu season. Looking through that paper was really eye-opening. There's also gonorrhea season and quite a few other seasonal diseases that you don't really generally think about. So highly suggest looking at that paper as well. One other thing I want to highlight is, you know, her work has really focused on diseases and disparities, which we'll hear about today. Some really interesting work she did was on proposing strategies during the Zika epidemic for how women could safely get pregnant in spite of the negative consequences we know could happen during Zika infection on pregnant women and their unborn children. She's worked on understanding how chronic health conditions could influence COVID-19 epidemic in the US. And then she's also highlighted, I don't want to go into too much detail, but she's highlighted some of the disparate impact that COVID-19 could have on women and girls and other vulnerable populations, as well as essential workers. So with that, I'll let her take it away.
Thank you, Spencer, for that very kind introduction. And so let's see if I can share my screen and get my PowerPoint going. Today I'm going to talk to you about some of the work that colleagues and I have been doing on COVID-19 in New York, and specifically thinking about health inequities. So this is actually a collaboration between myself and some other MIDAS members who many of you might be familiar with, that are at Boston University School of Public Health. And the person who led this is a PhD student, Reese Tsai, who did much of the analysis that was overseen by myself and Laura White. And so everything I'll be presenting today, you can find on a preprint we have out on medRxiv, and also this is in revision right now for a peer-reviewed journal. So when we think about inequities and social determinants of health in regard to the COVID-19 pandemic, we really have to split this into two different arenas. First is thinking about the probability of an individual acquiring infection. So the types of things that can impact your probability of getting infection may be local infection incidence in the community where you live, whether or not you have to work outside the home, or the number of close contacts that you have. Now, given that you've already acquired infection, or individuals acquired infection, then there's the pathological consequences of infection, which may differ, I'm jumping slides, which may differ from person to person based on their age and sex, any pre-existing conditions such as diabetes, obesity, heart disease, and then your access to treatment. And in this talk, I'm mostly going to be considering the acquisition of infection sites, so considering transmission. Now, one thing that we asked very early on in the epidemic here in New York City, or as a pandemic hit New York City, was whether or not we could data mine proxies for social distancing. So as all of you know, in the United States, it's really hard to get data on individuals' mobility and their contacts on a daily basis. So we wanted to know whether there was some very rough proxy that we would be able to get at a community level to be able to measure social distancing. And so what we turned to was transportation data. And for this talk specifically, I'm going to focus on subway data, which is relevant to New York City, but later on I'll mention traffic data. And so what we first did is we wanted to know, can subway data in any way reflect what's happening in terms of transmission of cases? And so on the left-hand on the right-hand panels, what I have are cases per 100,000, percent test positive, and tests per 100,000 in each borough in New York. And a borough in New York City is the equivalent to a county in any other location. And so we had these data for infection, and then we also had subway use data. So for every neighborhood in the city, which we have some 200 plus neighborhoods, we were able to get the number of subway swipes at every single turnstile in New York. So what we did is we measured subway swipes before the pandemic, so in a pre-pandemic phase, which was essentially January, February in New York, and then we followed through, this is what this plot on the right is showing, if you can see my cursor, we follow through the relative decline in subway use in each neighborhood, and each neighborhood is a different light colored line, and then we group these by borough, and we have the 4 boroughs with subways shown here, so Bronx, Brooklyn, Manhattan, and Queens. So we wanted to know, does the subway use data in any way inform anything that's going on in terms of transmission within the city? So what we did was we took an extremely simple approach, and we just took our subway use data and we took our cumulative case data for every location, and then we did breakpoint regressions on the log transform cases. So both of these had one had an exponential decline, the other had an exponential increase. So cumulative cases were increasing exponentially, then the city shut down, and then we got that flattening of the curve like we saw in many other places. So we wanted to know, does the subway relate to, longitudinal subway data relate to case data in any way? So what we did was we ran breakpoint regression for each borough's data for subway and for cases, and we looked to see if there were any relationships between what was happening in both of these. And what we found is that there was a consistent 28-day lag between when the breakpoint regression found that subway use started their decline, and when we had the flattening of the curve in each borough. And so this essentially led us to say, okay, well, we're going to use subway use data as some very rough proxy for the amount of social distancing in the city. As each borough slowed down, then we saw after a couple weeks later that this kind of propagated into a measurable decline in transmission that we observed in cases. And so with that, we wanted to know, because we have subway use data on a very, very fine scale for every single neighborhood in the city, we wanted to ask, can the subway use data tell us anything more specifically about social distancing by neighborhood? And so this is going back to considering, as I mentioned in the beginning, the probability of acquiring infection. So on a neighborhood level, we want to know, what can subway use tell us about acquiring infection? Now, one of the first things we did, because we had, actually it's 126 neighborhoods for which we had the subway use data, and we also have really detailed demography data and socioeconomic data from all 126 neighborhoods from the American Community Survey. So then what we did was we broke down subway use based on sextiles for income. So for every 126 neighborhood, if you just bin them based on their income, what does the subway use look like? And we found that the subway use decline in the pandemic phase was very strikingly associated with income. So if you see this curve in red, which are the neighborhoods that declined the least, those are also the poorest neighborhoods where median income was between $9,000 and $22,000. And you can see in rank order that the neighborhood, as income increased, the subway use decreased most dramatically. So what this is saying is essentially richer neighborhoods were able to slow down actually earlier, if you can see when their subway use started to decline, and then in their trough, they actually had the least subway use. And then we wanted to look at this spatially because we had such rich data. So this is a plot, each of these plots is a gridded plot for neighborhoods in New York City. And if we look back from February 29th, which was before our schools closed on March 16th, we see subway use, the colors I should orient you. We're looking at decline in subway use, where the least decline is dark blue and the greatest decline is bright yellow. And so what we see, February 29th, subway use is at its normal level. And then as we proceed to March 7th, before schools close, subway use declines a tiny bit in some neighborhoods. And then March 14th is around the weekend that schools close, we start to see substantial declines in certain neighborhoods. And this just continues and continues until we're out in April, which is where we're at this kind of plateaued level of subway use. And what I want you to take away from this is it's very patchy spatially. There are some places that have a very large decline and some places that have a very small decline in subway use, or relatively small decline in subway use. So we took all of our socioeconomic and demographic variables and we just asked, which variables have associations with subway use? And we took things like percent of individuals in each neighborhood in essential services, percent non-white, non-Hispanic individuals, median income, percent of people that work in healthcare, percent uninsured, percent over age 75, percent education, high school or less. So just a ton of variables from the American Community Survey. And then we asked, again, which of these has an effect on subway use? And what we found was that median income, percent of individuals in essential services, percent of individuals in healthcare services, and the percent of individuals who are non-white and not Hispanic or Latino was correlated with subway use. So,
Micaela, what's the values on the x-axis here?
Yeah, so on the values on the x-axis are essentially beta values for these regressions. So they're the coefficients. So for instance, if you look at median income, the beta value is less, it's negative, it's less than 0. So this is a negative association between median income and subway use, meaning that higher income means less subway use during the pandemic, and then all the others had positive betas, meaning that they were positively correlated. So if you have essentially, if you have a higher percent non-white, Hispanic, or Latino, meaning essentially Black, Brown, Asian communities, that the higher percent of Asians, Latinos, Black African Americans, then the more subway use you had during the pandemic phase. So that's how you interpret these values. And then because we had, sorry, I would explain this more in detail, but I know I only have 10 minutes. And then because we also had data on COVID-19, we used our cross-sectional data from April for COVID cases. And what we specifically did is we know that here in New York City that there is an uneven distribution of testing efforts across boroughs. And some of it is probably driven by socioeconomics. Some of it is driven by actual need for testing. But what we did is we took cases and we adjusted cases per 100,000 by the testing effort in each neighborhood. And then we looked for whether or not we had associations between rates of COVID, which now I'm showing in the plot above, COVID rates and all of these socioeconomic variables. And we found that all of the very same variables that impacted subway use also impacted the cumulative COVID cases that we had through April. And just to orient you a little bit for New York City, it was March and April that we had the majority of our cases roll in. So the time that this cross-sectional analysis was done was at a point where we're kind of in the midst of our outbreak here, and it's since has gotten under control. And we also saw that subway use itself was associated with the cumulative COVID cases as of April, which we would expect based on the longitudinal data that I showed in the beginning. But what we learned from all this is that in New York City, and I would actually say that in the United States overall, there is a very strong association between where people live. We still have very highly segregated communities in this country, your race, your income, and essential work. So these things are all very, very tightly associated. And these things all come together to shape individuals' probability or risk of being in a community that has infection that is transmitting at a relatively high level compared to other neighboring communities. And so the way that we interpret this is that we have all of these very interconnected factors. And in New York City, subway use is our measure of human mobility. And what happens is that lower income neighborhoods in New York have a higher burden of COVID-19, but these communities are also communities of color. They're also the communities that bear the brunt of essential services for our city. And we're assuming that people, especially during the height of the outbreak here, that people were still using the subway in poorer communities and communities of color, and presumably this was out of need, not by choice. And so we are terming this social distancing inequity, and trying to push the idea that we need to consider, as cities are locking down or coming in and out of lockdown, that there are inequities that determine people's ability to social distance, and at a community level, the amount of social distancing that is available to that community. And it's the ability to be able to work from home and not go and take the subway or go out for work is very much driven by social determinants and economics. Now, subways are quite unique in the United States. And so for other cities, especially car cities, what we're trying to do is build out data, traffic data. And so right now, myself and a colleague who's actually an air pollution scientist have been creating algorithms for scrubbing Google traffic maps on a 15-second interval. And we can do this by neighborhoods, we can do this by cities, and then creating longitudinal data for traffic. So this is what I'm showing here at the bottom, our time series for heavy traffic, light traffic in Manhattan throughout the pandemic. And we essentially can grid up cities. So here on the right, these are plots for Manhattan, and we can see in red, it's kind of hard to see in this plot, but in red are the high traffic areas pre-pandemic, and then once those streets turn green during lockdown, that's when you have very little traffic, or just free moving traffic. So very soon, we will be able to generate these types of mobility, neighborhood and city mobility data using Google traffic for other cities as well. And hopefully other research teams will be able to use that for studying social distancing. And that's it. That's probably about 10 minutes or over.